Things are going well.
All right, hello everyone. We'll get started here in just a few minutes.
Chris, you're planning on MBA?
Yeah, we are live now. So it looks like there's a handful of people joining us right now. We'll wait until we'll give them about 4 or 5 more minutes to get logged in.
Wonderful. Yeah, thank you. Thank you. Thank you. Doc, I wanted to ask you, but this can wait, about how the splint, the lower splint that we make for you, how that is implemented. I'm curious, but again, it could be another time.
It works great. I've had I've had a couple of patients where after 4 or 5 months I remove the arms,
Got
but
it. Got it.
I use it for more younger people, and I'm not sharing that. I'll touch base with you, but I don't have it in my slides.
Yeah, yeah, all good. All good. Yeah. But I can see how it just a little bit easier to wear, more user friendly than like a two-piece thing.
Especially if they have a very narrow palate, or it's a very young patient where occlusal changes are less with that design rather than a Mora design.
Gotcha. Gotcha. Very cool. Awesome.
I also like that design if somebody bites their cheeks. So
Yeah, very cool. Yep. We can definitely think about modifying it a little bit to maybe round things off and just make it a little bit more comfortable.
yeah, they come out really good. I haven't had to adjust most of them. I was going to say anyone, but I would say most of them I haven't had to adjust them. So
Wonderful.
and a couple of times I haven't sent a bite, and still I didn't have to adjust it. So
That's great. Awesome.
Which for everyone that's listening, we do not advise, but if it needs to happen.
What's that? I'm sorry, what?
Here. We'll get started here in just a few more moments. I said everyone that's listening, sending one without a bite is not advised, but
I guess it depends on what you're making. Yeah, depends on what you.
Like I'm not making a sleep appliance. I'm making really a stabilization with slight anterior repositioning. It's easier.
Right on.
I'm doing 45 minutes, 45 minutes, and then questions.
That's perfect. Yeah. Yep.
We'll give just a few more minutes here.
How's the weather for you all? I always have that that question.
It's crazy. Like day before yesterday, it was like 35 degrees. Today it's 50. Everybody's sick. It's crazy.
It's just a big shift in weather patterns.
Yeah.
I think we see a little bit of that here too.
We had some snow spitting today.
Oh boy.
Wow.
I was like, I'm over this. I'm ready to come to San Diego.
We're almost there, Trish. Come on down. Come on down. We'll go for that hike that you owe me.
I won't hike there now because there's giant snakes that Frank runs into when he hikes.
No, I think it's just me. I'm just a lucky one that runs into funny stuff. The other time it was a tarantula and a what was that? I forget the type of bug that apparently injects its eggs into the tarantula and they like grow in. It's kind of gross, but yeah.
That's cool.
Yeah, but so I saw that happening as well on the same trail. So I won't take you there, I promise.
Yeah, okay. I don't do snakes.
Shall we start?
Yeah, we'll get started here. There's still a fairly consistent stream of everyone signing in, but we'll go ahead and get started here. For everyone that's joining, thank you so much for joining us this evening. Just so you know, you are on mute and your cameras are turned off. That is how it's supposed to be. So if you do have any questions today throughout the webinar, feel free to raise your hand and I can unmute you, or use the chat box, like the question and answer box. We'll be monitoring that to get those questions answered as well. The best way to view the webinar today is going to be in speaker view. So if you click the view button in the upper right-hand corner, that'll have the option for speaker view, so you can side by side see Dr. Chandwani in his PowerPoint. It's just the best way to kind of format the viewing for today. Alrighty, so as you know, today we're going to discuss the ins and outs of repositioning occlusal appliances. So feel free to ask those questions throughout the webinar. And live attendees, at the end, you'll receive a promo code, so make sure you stick around for that. I will pass it over now to Frank so we can talk a little bit about True Function for those new faces on, and then we'll get started.
Wonderful. Thank you, Trish and Dr. Chandwani. Thank you so much for joining us. We really appreciate you sharing your expertise and your time, very valuable time. So thank you again for being a part of this. And
Pleasure.
yeah, it's a blessing to have you. Everyone, thanks for joining us this week. You know, we do this once a month, and we're really appreciative of Dr. Chandwani, sharing his knowledge with us, and a little bit about True Function. This is our 25th year, so we've been doing this for a little while now, and all we do are oral devices for treating sleep apnea, of course, on the medical side. And the dental devices, the splints, the TMJ appliances that we make. And that's all we do. That's all we do. We don't do crown and bridge. We don't do dentures. We don't do anything else. So we truly specialize. We believe we are amongst the experts in the industry. So any way we can help you to resolve an issue or really just be your support system for oral device, that's what we're here for. So again, it's a pleasure to have you. Thank you for spending your evening with us, and we hope you find much value from the presentation. Thank you. Thanks again.
Alrighty, I'd like to introduce one of my favorite people and a dear friend of ours here at TFL, Dr. Chandwani. So Brijesh Chandwani is a residency-trained oral facial pain and TMJ specialist who specializes in complex facial pain conditions, including TMJ disorders, trismus, jaw spasms, trigeminal neuralgia, atypical facial pain, trigeminal nerve injuries, and headache disorders. Additionally, Dr. Chandwani is a licensed acupuncturist and often incorporates acupuncture, supplements, and natural remedies as a first step in treatment as possible. Dr. Chandwani's philosophy focuses on precision diagnosis and understanding underlying mechanisms and complicating factors. Dr. Chandwani has extensive training and more than 15 years experience in modalities such as nerve blocks, trigger point injections, prolotherapy, TMJ injections, occlusal orthotics, and other mouth guards. Dr. Chandwani has authored numerous scientific articles in peer-reviewed journals and is invited reviewer for the Journal of American Dental Association and annuals of otology, rhinology, and laryngology. He teaches oral facial pain and sleep medicine to postgraduate residency programs in dental schools. And additionally, he has lectured nationally and internationally on various topics of oral facial pain. So thank you so much for joining us today. I'll pass it over to you.
Thanks, Trish. All right.
You're welcome.
We'll talk today about repositioning appliance. So technically, all appliances are repositioning appliance. I'm glad True Function was kind enough to invite me. It's a pleasure to talk about one of my favorite appliances. That's kind of so, like I said, pretty much any appliance you do does reposition the mandible. I should have changed it to anterior repositioning appliance. So anyway, so if any of you have seen me talk, you know I like to talk about clinical cases and kind of take a step back and talk about science and practical implications. Okay, so we'll talk about a case, we talk about anterior repositioning appliance, how do they fit in orofacial pain practice, clinical consideration, and we'll conclude. So 25-year-old female, jaw pain clicking since several years. Saw her about a couple of months actually ago. It's been about, yeah, saw her in December. Persistent jaw clicking pain, clearly quality of life is a little bit down. Light sound sensitivity since years, indicating some migrainous characteristics or neuropathic pain characteristics. And several hours every day since 3 months, seems to be getting worse. Uh, some medical complication was happened about 2-3 days before I saw her. When I saw her, she was okay. Good range of motion, early to mid click, and repositioning the mandible just a little bit forward, and she was very comfortable. She was like moving well. So, and that's important in this case, and we'll talk when I look at the X-ray. So, some muscle, a lot of muscle tenderness as well as joint tenderness. So, and this was her X-ray. Whenever I'm suspecting a joint problem, I tend to take lateral TM joint X-rays, and you could kind of appreciate some osteophyte on the left condyle. This is not the best image to screen for it, but a 25-year-old, if I take a CT scan, I'll see a fair amount of osteoarthritic changes. It's a snapshot in time. This could have happened 10, 15 years ago rather than in recent times. So X-ray just tells you the condition. So it shows arthritic changes. It doesn't state active disease state. So, and typically if range of motion is good, it's unlikely that this patient is undergoing degenerative changes. Second indication tends to be if the cortical margin is well defined, despite that osteophyte, usually you will see more darkness in the margin of the condyle. So here you could kind of see the beaking, but it's really well defined. On the right side is really well defined. So what's my diagnosis? My diagnosis was internal derangement of the TM joint arthralgia, maybe acute, maybe chronic. At this time, I really don't know. Only a MRI can state an active disease state if there was effusion, and some muscle pain. So for internal derangement, maybe, there's good data to show that you really don't need to treat just clicking or joint sounds. Joint arthralgia, NSAIDs, I did actually start her on meloxicam. Muscle myalgia, maybe a muscle relaxant, maybe not. If it's secondary to joint problems, NSAIDs would suffice, while it's not. So, don't know why I repeated the slide. Okay, so what did I do in this patient? I scanned her teeth. I sent the scans to Frank, and actually not Frank, True Function. Don't know who worked on this. And I took an anterior bite to, this is where her clicking was reduced. And about, this is kind of the finished product that she received in a few days. Okay, so anytime that patient is young, I was just talking to Frank, at times if this patient needed a fair amount of anterior repositioning, I tend to like a dorsal fin kind of device, which we use for sleep apnea, where the protruding arm is more on the buccal of the lingual appliance, buccal of the mandibular appliance. And in her case, I really needed very slight anterior repositioning, and so it worked. So these are the common kind of anterior repositioning appliance. It could be a mandibular appliance or a maxillary appliance. I try to look at if it's impacting airway, palate is narrow, I go with a mandibular appliance. If the palate is nice and wide, arches are wide, I really prefer a maxillary appliance for this. So where do they fit in orofacial pain literature? So before we talk about where to fit in, what's the mechanism of oral appliance? So I really took a step back to talk about mechanism of all oral appliances because most studies haven't really divided this into subgroups. So repositioning appliance, stabilization appliance, most appliances have similar mechanism. It alters joint mechanics, behavioral. It can work like a biobehavioral appliance or biobehavioral medicine. There's definitely it's been called an elegant placebo. So you could, and you want that, why not? And then if it's a self-limiting condition, a lot of times the patient is going to get better. So no matter what you do, they just do regress to mean or they do get better. So that's been mentioned in literature. So,
Dr. Chandwani, we have a question.
Mhm.
In this case, in the indication in this case for anterior repositioning, the fact that there is intermittent locking, not the click.
Yeah. So we'll talk about that in a little bit. Yes.
Thank you.
Yeah. So a repositioning appliance is really the foundation of a lot of functional appliances for orthodontics, sleep appliances. Pierre Robin, I believe, was a French dentist who in 1902 fabricated the first monoblock for glossoptosis, which is kind of weakness in the tongue syndrome. And till today, we use pretty much the same design. Maybe we cover occlusion so that there's no extrusion, but it's 120 years later. We're still using kind of some of that. It's okay. So going back to the case, going back to kind of using repositioning appliances. These are the diagnoses I like to use it for. There's good evidence that repositioning appliances are really a treatment of choice for anterior disc displacement without reduction with limited opening and or pain. I like to use them for anterior disc displacement without reduction, which is accompanied by snoring. I couldn't find literature on that. And then you got to always think of prognosis. If somebody has just clicking, and thank you, whoever pointed out that point about clicking and locking. There's number of studies showing that disc displacement with or without reduction, which is not associated with pain, not associated with locking, tends to get better. And almost 65% of patients get better by year 2, 18 to 24 months. Within 6 months, almost 30% get better. So your chances of success, the patient's prognosis is good even without treatment. So always kind of think of that. And then there's definitely a very small subset of patients. I actually had a patient 2 days ago, and he has disc displacement with reduction, but it is annoying the hell out of him. He's like, Doc, I'm just miserable. It's been going on for almost 7, 8 months. So, and I told him the same thing. I'm like, listen, you're already with this for 7, 8 months. There's a really good chance in the next 6 to 12 months, this will resolve even without treatment. He's like, Doc, why don't we try something? I was like, okay, everything has a tiny amount of risk. These are really simple appliances. Risk is not great, but still, there's always a tiny amount of risk. I got a question, what about disc displacement with reduction with intermittent locking where the patient has normal range of motion? A lot depends on frequency and how long they lock. Okay, so the intensity of locking. If somebody is locking for 1 to 2 hours, once a year, no problem. But 1 to 2 hours, every couple of days, couple of weeks, that can translate into a trismus situation. Second thing, disc displacement with reduction, with intermittent locking, with pain, and it could be headache, jaw pain, then you want to treat it. And then, of course, you got to look at the radiograph if there is significant degenerative changes or something that sticks out, then you got to treat it. So, so clicking, I really don't like to treat clicking. I was just talking to you about Jordan, who I saw a couple of days ago. Most patients, clicking gets better. This was a really good study which was done in Finland. 128 kids, they were assessed at age 14 through 23, and only 2% of patients had clicking at age 23. So they had consistent clicking. None of those patients went from clicking to locking. There's actually a different study where it shows that none of clicking progresses to degenerative changes or locking or any significant arthritis or any significant pain. So there's really good data on anterior disc displacement with reduction and without reduction that it doesn't progress to a problem. So this is a study where it was an 18-month study where Sato, this is a Japanese group, they looked at subjects who had locking, about 40-odd patients, and they were followed up. And they found that 34% at 6 months, their symptoms were better, range of motion improved to almost normal, 50% at 12 months, and 68% at 18 months. So I always tell patients, I usually say 2 years. I was like, there's a 60-70% chance that you'll be better if I see somebody who has clicking and locking but has no discomfort. And it's important. A lot of times educating them gives them peace of mind, and the symptoms reduce with education. So it's a powerful tool. So evidence-based medicine kind of treatment shows that most orofacial pain conditions get better with conservative treatment. Okay, and you don't need to reposition the mandible because they can be associated with occlusal changes, trouble eating. I use repositioning appliance in patients who don't respond to stabilization appliance. And this could be locking, this could be pain, it could be teeth grinding. I actually did a patient today who's severely, she's chipping teeth, she's in her 50s, and she has like her incisors and canines are like knife edges. The dentist is frustrated. He did a bonding about 3 weeks ago and the bondings were off. So in her case, I am actually planning a repositioning appliance. Very slight repositioning appliance do work quite well in patients. The biggest indication for a repositioning appliance is intra-articular disc derangement, which is associated with trouble. So this was a fascinating study where they compared different kind of appliances for internal derangement. So group 1 got this anterior repositioning splint, okay, and then group 2 got the combination of these two splints, okay, the daytime and the nighttime. So the top one is the, I believe, is the daytime appliance, and the bottom one is the nighttime appliance. And they found that both groups had similar outcomes with regards to pain, noise at 6 months. Group 2 had less discomfort, although the first month, the group 1 was better. So it's really very mixed results. It's unclear. And that's what I see in my experience. There's no clear-cut rule that you need an upper repositioning appliance or a lower. You could pick as patient preference is really the key. This was a fascinating kind of literature about what do appliances do in real time or kind of not real time and to disposition in relation to condyle. So, and it's an old study where they looked at disc displacement with reduction, without reduction. So the yellow is where the disc is. I kind of colored it so that it's easy to see. And the figure C, which is the middle of the top. So this is without an appliance, and E, this is with an appliance. And you could appreciate the recapture of the almost full recapture of the disc. Okay. And this is with a repositioning appliance. Okay. And then on the right side, you could see again, jaw with the jaw opening, a good recapture of the disc. So these are some examples of this is something I did it in-house repositioning appliance, made a SX. I just find lab appliances are better tolerated. So this is kind of my cheat sheet for oral appliances. If somebody has jaw locking, snoring, then I'm using an anterior repositioning appliance. Okay, and please feel free to email me, and I'm happy to share my slides, or email Trish or Frank, and I'm going to give them the slides also. So I prefer stabilization appliance in patients who have recently had orthodontics, who are young. My idea of young is less than 30 years old, because the bone can remodel much quicker. While I prefer repositioning appliance in like severe cases. There's definitely a risk of occlusal changes, risk of and depending on the design, some patients with a repositioning appliance, especially where they have a negative ramp on the palatal, they can have soreness in the anterior teeth. So, and in those cases, I use a stabilization appliance, or I give them SX with a repositioning maxillary appliance. So straightforward. So now comes the clinical kind of consideration for appliance therapy. Almost all appliances have the possibility of moving teeth. Teeth are moving even without appliances. So that's kind of the challenging part. There's studies showing that an appliance like a sleep apnea appliance, almost 25-30% of patients have occlusal changes with a sleep appliance over a 5-year duration. And almost 10% of patients with CPAP have occlusal changes over 5 years over the same period. So teeth are moving. So interestingly, they didn't look at non-sleep patients, how much is the movement. So I suspect around 5 to 10% will have occlusal changes even without anything going on in their mouth, because our bones are constantly remodeling. So under the influence of behavior, disease, under influence of breathing patterns. So there's a lot of variables going on. Having an informed consent, talking about those is definitely helpful from a medical legal standpoint, but also from practical standpoint. If they read something about it, they are okay with when that thing happens compared to when they're surprised. Sorry. The design of be it a repositioning appliance or a stabilization appliance, you have your lab is a wonderful resource. Talk to them, figure out what kind of design you need. Number of times I call up Frank or I call up Trish or message them, listen, can you do this if I want it? And I'm amazed how many kind of how much precision or uh, how much modification or personalization they can do, and they do some fascinating stuff. Uh, uh, it doesn't matter if somebody has parafunction, somebody is a mouth breather, because the appliance is really working when their jaw is closing. When we are sleeping, our jaw closes every 20 seconds. Every time we swallow, the mandible closes to kind of so that the saliva is uh, goes from the oral cavity into the pharynx. Uh, in the GI tract, sorry, not the pharynx. So uh, that's the moment an occlusal appliance functions, be it for internal derangement or pain. Uh, I always tell patients, this is not for you to rest your teeth against. If their teeth if are engaged with the appliance, their muscles are tense, it may not help their pain enough. Uh, can appliance make symptoms worse? Absolutely. Appliances have that, they're like medicine. So the efficacy is 70 to 80% for different orofacial pain conditions. So they work quite well, but patients do kind of have the possibility. I always tell patients, this is like medicine. There's no guarantees. If it there's no refunds, things just go wrong. People get knee surgeries, knee replacements, and it doesn't work out. And that's like hundreds of $1,000 and they're disabled. So I make it a point not to kind of provide refunds, but I educate them beforehand.
Dr. Chandwani,
Yes.
back in the informed consent, do you have your patients sign informed consent for potential occlusal changes?
Oh, yeah, absolutely. My informed consent has that. I'm happy to share my consent. It talks about that. Again, email me and I'll share it. Uh, how often should an occlusal appliance be used? So I usually use a repositioning appliance, often at time for until symptoms subside. But after like 2 to 3 months, if they're to use it every day, I often uh, alternate between a repositioning appliance and a Essex. So I often at times have my office make top and bottom Essex along with a repositioning appliance. And if it's a last month, I had a 20-year-old patient, and I made her an AM aligner with it too because I'm scared that she'll have occlusal changes. So you have to improvise according to the clinical scenario. But I would say half of my patients, I give them a repositioning appliance and top and bottom Essex so that, and depending on how soon they get better, once they're like 50% better, once they tell me 3 to 4 days in a week, they're doing well, I switch from every night to every other night and I alternate with Essex. And that strategy has worked quite well. I'll wrap up. Remember, a lot of our patients, there is psychosocial, psychological comorbidities. The physical pain is real, even if there's no objective test. Most of patients, x-rays, radiology, exam is normal. Be tactful, show empathy. Uh, Allow the patient to express themselves. And by that, it doesn't mean you can allow them to go on a tangent. I uh, um I feel my time is precious. I make it a point. My initial eval is close to an hour, but I rarely go over. So learn not to kind of. I often use the words. If you, I'll forget if I don't ask. Can I interrupt you? And then I try to bring them into focus. Uh,
Couple more questions, if you don't mind.
let's finish and then I'll take questions.
Excellent.
Okay. So I'm very I'm very candid about what do I kind of understand about their pain or discomfort. So if somebody, as soon as they say they're locking 1 to 2 times a month, I tell them, do you think 1 to 2 times a month, I may disregard it if it was not a progressive problem. Would you agree with that? So I'm kind of expressing my opinion, but I'm trying to understand their discomfort. And some patients say, yeah, okay. And some patients say, no, it annoys me a lot. So this is where you understand what their discomfort feels like. And everything takes time. So treatment takes time. At times, diagnostics take time. Somebody, if they need an MRI, it may take Connecticut. Usually takes us like 2-3 weeks to get an MRI. So, and problems happen when there's not proper communication. I feel that's kind of the root cause of all problems. All right, we'll switch to questions. Thank you guys for listening. Hopefully. Okay. What do you use for an aligner? I've used a number of questions, a number of different things. I have a thermoplastic material. I've used the thermoplastic AM aligner aligners. A couple of times I've actually had the lab make morning aligners. So at times it depends on if a patient is really very proactive, I'm okay with using a thermoplastic material. But if a patient I feel is extremely busy, and if it's not a convenient gadget, they won't adhere to a treatment plan. I have the lab make me a morning aligner, and I charge them cost price. I think the lab cost is like, if it's $50, I charge them $50. I don't kind of upcharge that. And they usually, if they're paying $50, I find that the adherence is better. I learned it from Alex Swan, who practices in Virginia. A couple of years ago, he mentioned that, and I find that the adherence, if you charge them cost price, it's better. Contraindication to anterior repositioning appliance. That's a big one. The biggest contraindication is if there is periodontal disease in the anterior region. Okay. Second one, if let's see, young patients, I think before the growth is done is a big contraindication. And I don't have anything else in my mind off the back. So next question is, how do you alternate with Essex? I usually go, if somebody has, I often ask how many pain days in a month. So if they have, say, 25 pain days, as soon as they are close to 10 days or maybe 8 to 10 days of pain per month, so we are at like 50% reduction, I often switch to that. And or at times in 6 weeks, they're a lot better. And then I switch to Essex, alternate with Essex. I had a 24-year-old who's doing really well this week, and I told her, you're just going to use the anterior positioning appliance on Mondays and Wednesdays, rest 5 days you're using retainers. And history, I've found that if they have a history of orthodontics, they tend to show occlusal changes much faster. So I've learned it the hard way. So can you describe how to take a bite for repositioning appliance? So that depends on what you're trying to do. If you're trying to use it for severe bruxism where stabilization appliance has failed, I usually do a 1 to 2 millimeter anterior repositioning with around 2 to 3 millimeter vertical opening. If it's disc derangement, and if I'm able to get the mandible or condyles to translate, and I'm able to, at some position, I'm able to reduce the disc really easily, I take a bite where the disc reduces. So it's it's dynamic. It's really depend on what the patient needs. It's very different than sleep. Do you have any experience with flex, tap, full arch arm aligner versus I do not. I do not have experience. Mona has a question. I have seen patients coming with issues with wearing SX type retainers post ortho or during Invisalign. Do you have any observation or thought on? So I'm saying I need more information as to what kind of issues. Are the teeth moving? Are they having pain? So I can comment if I have a little bit more specific. I do not do anterior repositioning appliance 24/7, Joan. I always do nighttime. Occasionally, if it's somebody who's locking very severely during the day and they're unlocking with an appliance, I would do a daytime appliance for 2 to 4 hours. But I'm not a fan of 24/7 oral appliance. Uh, uh, Can you comment on acupuncture that you use with occlusal therapy? That's a loaded question. Let's see. I do acupuncture. One easy kind of incorporation of acupuncture tends to be if somebody has severe headaches, sleep problems, or neck pain. I'd often combine acupuncture and occlusal appliances. What you use, do you use appliance with posterior contact in anterior repositioning devices, or do you disocclude the posterior? Frank can answer that. It varies a lot from patient to patient. So if it's the example I was giving you today, my 50-odd-year-old female who is a severe bruxer, I emailed, my instructions were, please reposition and please fabricate an anterior repositioning appliance with slight disocclusion on the posteriors. So I told the patient your teeth could shift, but I would rather take that risk over how she's damaging her teeth.
Doc, if I can touch on that just briefly. Again, I think that's probably more clinician preference and experience, right, and knowledge, because understanding the risk of not having posterior occlusion versus having posterior occlusion, and understanding what your patient's needs are clinically, that's really what will allow you to make that decision. And of course, sharing that with them.
Yeah. Over the years, I've had several patients where I start with posterior contacts and patients actually don't do well, and they take off posterior contacts for like 3 months and they're doing well. And then long term, I like posterior contacts, but if you spend like a month in my office, you'll see me giving posterior contacts and none in kind of equal numbers in my patients. How do you take a bite for sleep appliance? So I use a George gauge with my scanner. I think it just made things much easier, the digital scanning. Issues of pain and clicking. Mona, I need more information on that question.
Dr. Halim was the one that asked earlier about the Invisalign.
Oh, okay.
And those aligners, and she was specifying that was the issue.
Okay, so yes. So if somebody is able to activate those muscles and the joint, they will have pain and clicking. So at times, if somebody comes in, often at times, I would ask the lab to make a 2 millimeter SX instead of a regular 1 millimeter or 0.75 millimeter SX. And that will help the clicking, especially if it's an early disc displacement. So an early disc displacement will get better with like a 2 millimeter. Pain is a tough one. It could be due to muscles, it could be due to joint. So you have to figure out where it's coming from and strategize. Sometimes it may be parafunctional or not. What function does the SX retainer do when not using the anterior repose? So any appliance, even a thinnest of even a bleaching tray, has a biobehavioral kind of role. And second, it does allow the condyle articular disc relation to change. And at times the change is, even though it's not a positive, enough of a positive change, a slight change can be enough to kind of cause a change in behavior where the resting mandible. So with the repositioning appliance, I should have put this in my slides. The goal is really to kind of reprogram the resting mandible to be a little forward, enough where the movement between condyle, articular disc, and the maxilla, the whole that complex, the movement is friction-free or with least friction. So, and it happens, it seems studies have shown even without treatment in a year and a half, the brain is able to do that. Some people just need that additional crutch to condition them there. And SX is a very small crutch compared to a repositioning appliance. It's more, I like to call it orthotic or orthopedic appliance compared to my SX is over-the-counter orthotic. Rationale for transitioning from anterior repositioning appliance to SX versus full occlusal flat plane. So that it's depends on the patient. So if a patient had ortho, has concern about occlusal changes, I use SX. If a patient has severe parafunction or morning tension, muscle pain, I use a full occlusal flat plane. So it varies from patient to patient. But I prefer SX just because they're much more forgiving compared to full occlusal plane appliances are not as forgiving. When you, I've seen a number of patients where after 5-10 years, there's issues with that. But that's another lecture in the making. Any difference between acute and chronic disc displacement without reduction? Absolutely. Acute disc displacement without reduction may not even need an appliance. At times, if it's, I have patients where they're locked and I see them and I'm able to unlock them either by injections or manipulation, I would give them a temporary appliance like a quick splint if they need to, or sometimes not even that, especially if it's associated with a dental visit. If it's associated with, say, a growth spurt, they may require treatment. But I always kind of, if it unlocks, I give it time. And I'm pleasantly surprised how many people don't come back. You've been a really good audience. I got a lot of questions. I always love that.
All right. Dr. Chandwani, would you mind going back to that second slide for me, please?
Yes.
All right. If you have any more questions, put them in the chat box while we finish up here. Thank you, everyone, of course, for joining us. I see a lot of familiar faces that we see weekly, which we love, or excuse me, monthly. So we love to see that. So thank you for joining us again for those and those who are new. We do this every month, like Frank had mentioned. So I'll put the registration link for our next webinar in the chat for you in case you want to join us next month. As for the special that you see on the screen, if you order any of those Mill deprogrammers, before next Friday the 5th, you will get $30 off your deprogrammer. So there's a promo code right there. If you aren't a True Function client and you would like to send us those cases, I did put the new account form link in the chat box. So feel free to join us, and we'd be happy to help you with any of those lab needs. Our next webinar is going to be on Wednesday, April 24th, and that is with Dr. Terry Bennett on the comprehensive TMD and sleep exam. So we'd love to have you join us for that. And like I said, that registration link is in the chat for you if you want to join us. We will be emailing the recording of this webinar. So it will come out, I would say, about early next week, end of this week. So keep an eye on your email for that if you want to review that. And then if you have any more questions, feel free to drop them in the chat and we'll get some final questions answered before we end today.
Again, I want to thank you, Dr. Chandwani, for joining us and again, spending your valuable time with us and your sharing your valuable knowledge and great questions, by the way. It was impressive. So thank you all for that and for spending your evening with us. And Trish, thank you for your wonderful work as always.
Thank you. Yeah, thank you everyone for joining
Trish,
us.
I'll email you my slides, so if anybody wants them, feel free to forward it.
Perfect. Yeah, you all should have my email. All of the registration emails are sent out through that. So make sure to reply back to that if you want his slides and his consent, if you want to send that over. Perfect.
All right. Thank you all.
Thank you, everyone. Have a
Wonderful.
good evening.
Have a great evening, everyone. Thank you.
Frank.
Talk to you soon. Thanks. Thank you.
Bye.
Bye, Dr. Chandwani.
Bye.